Thank you, everyone, for on the call tonight or this afternoon, wherever you may be in the world. Today, I'm very, very pleased and excited to present to you guys a presentation about socket graft management, setting patients up for success when we're considering dental implant therapy to replace missing teeth. So before we get started, I'd like to set up our talk today about a very common quote that we often see in literature and in presentations from the podium. The bone sets the tone, the tissue is the issue, but the screw is the clue. Now, we could obviously speak all weekend long about these three topics, but for all intents and purposes for today, we're going to focus on the bone. So before we get started, let's just ask ourselves a question. Where are we with dental implants now? It's not the 1960s and 70s anymore when we're worried about whether implants osseointegrate. Of course, we know now that implants osseointegrate. Our challenge nowadays is aesthetics. How do we get an implant to look like a tooth? After all, that's what patients really want. They don't really want an implant. They want a tooth. How they get there is often our problem. So if we flash back to 2005, let's say 9-10 years ago, the common procedure that we would do when we would encounter a periodontally questionable or hopeless tooth such as this one, we would often consider taking the tooth out and immediately placing an implant like we have done here. Obviously, we've always advocated atraumatic or relatively atraumatic tooth extractions. But at any rate, we would put the implant in immediately. I would prefer to index the implant at the time of surgery, which would allow my restorative dentist, being a periodontist, I don't do any restorative. It would give them the opportunity to then, place the final abutment at the time of surgery or soon thereafter, so we can make a provisional restoration to help preserve the tissue. After a period of time, we could then convert the patient to the final prosthesis, in this case a single crown, and we'd get a nice result. And that's what we would do, a large majority of the time. Now, the problem is that being a periodontist, and I'm sure those of you on the call or come from all various specialties of dentistry, we get these types of cases, such as this tooth number 10, where we have a very, very large periapical abscess that encompasses almost the adjacent teeth as well. What do we do in these types of situations? I mean, are we comfortable taking a tooth out and putting an implant in and grafting around it? For me personally, maybe at one time I was, but nowadays I get nervous. If we see a clinical situation like this with tooth number 8, you have a draining fistula. Obviously, we have some pathologic migration of the tooth as well from the loss of periodontal support. What do we do in these situations? I mean, can we just take the tooth out and put an implant in? What about these types of cases? And the longer you're into implant dentistry, whether you're on the surgery or the prosthetic side, the more of these types of cases you'll see, where you have dehiscences and fenestrations leading to thread exposure of the implant. We have patients like Katie here that come into our office. What do we do in situations like this where we have an attractive young lady and all she wants is teeth? She wants a nice smile. How did we fail her here in this situation? So the question is, where are we headed now? Once again, 9-10 years ago, maybe we would take out tooth number 7 and tooth number 8 and consider immediately placed dental implants and maybe an immediate provisionalization. But now, when we take these teeth out, you see these blown out facial plates, and that's going to be the focus of our webinar this afternoon, is how do we manage these? What do we do? What's the appropriate treatment? Now, I will propose to you guys that the most appropriate treatment option is going to be to regenerate the bone first, and then place in soft tissue as necessary, and then consider placing dental implants in a phased approach. So in this situation here, we've already augmented the ridge. This is at the time of suturing, and after 6 months, you can see when we re-enter the site, we have a massive amount of bone in which to place implants of the appropriate diameter, appropriate location, and spaced the appropriate distance apart. As you can see here, it's 3 millimeters between the two implants. So the goals for this presentation are few but significant. We're going to do a basic socket graft review. I don't want this to be like other socket graft webinars where all we do is teach you how to take out a tooth and how to just plug a hole with bone. We're actually going to talk about 3 different types of sockets that exist and how we treat them differently. I'm going to show you the good, the bad, and the ugly. We're going to show you some really, really nice cases, and we're going to show you some really not so nice cases, failures even. We're going to talk about how to regenerate buccal defects, blown out buccal plates. We're going to go over the grafting technique and the appropriate materials and why we choose those. And we'll also talk a little bit at the end of this presentation on how to do a ridge augmentation. So who uses bone grafts? So how popular is grafting among doctors who place implants? So if you look at all the data regarding who's placing implants and whether or not they put use bone graft materials at the time of implant placement, it's no surprise that you'll see that 55% of periodontists utilize bone grafts at the time of implant placement, followed closely by oral surgeons, and then our restorative dentists, and then the prosthodontists. So what is socket preservation? And I always bring this up because in implant dentistry, we always have a discussion about what's ridge preservation versus what is socket preservation. And the joke is that they're actually not the same thing. They're actually 2 different things. I always start this story with a gentleman that came into our office a couple of years ago. His chief complaint was that his denture did not fit after he had a couple of teeth extracted. And I looked into his mouth to do an exam. I noticed that 22 and 27 were missing, but the sockets just looked like they were not healing very well at all. Matter of fact, when I asked him how long they had been missing, he said almost 6 months. And I don't know about you guys on this call today, but when you look at those sockets, it definitely looks like it's been way longer than 6 months since the teeth have been extracted. So I asked him to show me his denture, and what he showed me was this thing right here. As you can see, and probably some of you guys are chuckling at yourselves, he had a 6-unit fixed bridge from number 22 to 27. They came out when he took his partial out one day, and he decided on his own to super glue the 2 pieces together, and there you go. That is what you would consider socket preservation. What we're going to be talking about today is not socket preservation. We're going to be talking about ridge preservation, or socket grafting. So let's go over some literature first. So we've been discussing socket grafts in our field as late as 1967, and with Carlson and Person, which is a very often cited piece of literature here. What they noticed is that as soon as you take a tooth out, you lose bone both in the vertical and the horizontal dimensions, with the horizontal dimension being the most severely affected. They also talked about the fact that you continue to lose bone throughout your life. This is seconded by Ohm and Solar et al. In 1992, where they talked about the changes in the body of the mandible and how once teeth are removed, you lose up to 60%. Most of this loss occurs early on, just like all the other studies say, but it also appears that the compact and cancellous bone is equally affected. If we look even more recently, as we go through some of this literature here, we look at J. Perio, this paper in August of 2008, examining the sockets that were grafted and versus not grafted, and what they found is that in the grafted sites, you get a higher percentage of trabecular bone and mineralized tissue, whereas ungrafted sites, while they did get some fill, the sockets tended to be filled with more connective tissue. So when we were first, talking about when socket grafts first became popular, we used to say that, if you, this is just referring to Gordon Christensen's summary that also supports the notion that 40 to 60% of bone loss occurs within the first 2 years of extraction and then continues on throughout the patient's life. But going back to my point about atraumatic extraction sites, we used to say that if you were really, really careful about taking out a tooth and preserve the labial plate, just like we have here in this side view on a CBCT, we used to say that if you preserve that labial plate, that you don't really need to graft, or if grafting wasn't all that necessary, because that labial plate will preserve the dimensions of the ridge. And we now know that with papers on the bundle bone theory that even if you do a really nice job of preserving that labial plate, as you can see here on the right side of your screen, you still lose that labial bone. Some other recent papers, and we'll talk about this Nevins paper here in a second, that talk about, even with perfect socket grafting, you still tend to lose some of that buccal or labial dimension of the bone, typically around 20% or less with socket grafting. So the reason that is because that labial plate is mostly bundle bone, which gets its blood supply from the periodontal ligament, the periosteum, and the alveolar bone marrow spaces. So as a matter of fact, since you lose about 20% or less, even with socket grafting and preservation of the labial plate, some will say that further soft tissue augmentation is necessary as well in order to achieve the maximum result for the patient. So when we talk about the fate of the buccal wall or the labial wall, Nevins, and this is in the International Journal of Perio and Restorative Dentistry in 2006, he talked about also comparing grafted sockets versus non-grafted sockets. About 80% of the grafted sockets had less than 20% of buccal bone loss. About 70% of the non-grafted sites had greater than 20% of buccal bone loss. So the point here is that not only does socket grafting work, but even with perfect socket grafting, you still lose some bone. Okay, so that's not to say that if we do an excellent job that we're going to get 100% of the ridge preserved. You will still lose bone, which is why bone grafting at the time of implant placement is often warranted. Also, once again, soft tissue grafting is often necessary as well. So why do we socket graft? So why do patients care? I mean, we know, we just presented to you the literature, but why do patients care? If we look at tooth number 7 here, this patient obviously has a labial defect here that's going to compromise his long-term implant result, and this gentleman as well. If you look at his upper first left bicuspid and his lower left bicuspid as well, you can see, obviously the buccal defects that are present and the challenges it will pose to us as the clinicians either placing the implant or restoring it. And of course, this patient here is missing these lower right molars for several years. We commonly see not only the ridge defect in the horizontal and vertical dimensions, but you also see some soft tissue deficiencies as well. So socket graft manager, let's summarize this up. Why graft a socket? Well, it's the simplest and most predictable bone graft any of us on this call will ever do. It's important for aesthetics. Remember, bone sets the tone. It's often necessary to optimize implant position, size, and placement. It's important to protect the adjacent teeth, which may have been affected by periodontal pathology or other types of pathology adjacent to teeth that are missing. We can also use socket grafts to treat bone loss. So if you imagine for me, if you will, number 29 and number 30 are scheduled to be extracted. Now, if we were to just extract these teeth, imagine for me, if you will, what would happen to the distal aspect of number 28? Does this bone just fill in on its own? Well, maybe it does, maybe it doesn't. But our best chance to minimize the amount of bone loss and to maximize the health of this tooth here on tooth number 28, the best chance for the patient is going to be with the socket graft. This is actually a relative of mine, and she was obviously is going to be missing tooth number 30 due to non-restorable caries, as well as through and through furcation involvement from periodontal issues here. Now, certainly an implant could probably be placed without grafting, but it would be difficult to make the argument that the implant position would not be compromised in some way. And once the implant position is compromised, then of course that will dictate and affect the crown height space, et cetera, for the final prosthesis. What about this case here? Certainly number 19 needs to be extracted, but what do we do about all the bony destruction around this distal root and how it's affected the mesial aspect of that second molar? Here's another case in the anterior aesthetic zone, tooth number 7. This gentleman is obviously in need of an extraction, but how do we manage this case? I mean, immediate implants, once again, it's not a question of whether or not we can get an implant to integrate. It's a question of how it's going to look for the patient later on. And of course, this guy here, he came to the office after having an extraction of a central incisor back when he was a teenager. It's now post-operatively, 15 years later, and the socket has still not healed up properly. So I asked myself all these questions. What could we have done to have prevented some of these aesthetic deformities that are going to affect the patient's final outcome? Here's just a CBCT detailing, and I use this a lot for during my consultations with patients, is that look at what happens once teeth are removed. You definitely lose the horizontal ridge width compared to, on the other side, the contralateral side here where that first molar is still present. You can see how wide that ridge is compared to the left side where the teeth are missing. So let's talk about implant aesthetics. Where's the implant on this case? This case is nearly 10 years out, and 10 years ago, these implants that were placed here are the classic BioHorizons, external hex Maestro implant, which is no longer even being sold. But if we follow the principles of bone grafting and soft tissue aesthetics as well as implant prosthetics, we can get a nice result that lasts the patient a long time. Certainly, we have some staining involved, but the implants here are number 6, number 8, number 9, and number 11. But the patient's very, very happy and is very pleased, with the overall symmetry and result and changes that it's made for her smile. This is another rather classic case here. This is also an implant that's, it's just a classic implant, internal hex. It's the BioHorizons laser lock internal hex implant. Once again, it's and the implant here is tooth number 8. Final aesthetic result is very acceptable to the patient, but it's not. While implants do make a huge difference in the final outcome, it all starts with what we do with the bone. Where's the implant? Well, obviously here, guys, it's tooth number 9. So what happened? And these are the questions I ask myself. Once again, it's not a question of whether or not we can get an implant to integrate into the jaw. That's the easy part. This part is the difficult one. I apologize for the quality of this photo. It was actually emailed to me because the referring doctor was wondering if we could salvage this by using alloderm or some type of a soft tissue graft. And, of course, the question is a resounding no. So what is the secret to growing this bone that we're talking about here? It's proper planning. We've got to plan this case as soon as the patient walks through the door. We're going to talk today about the types of materials that work, and you'll be surprised at what you need and what you don't need. We're going to talk a lot about technique and go over several cases, and we'll gently touch on some of the patient factors that affect our decision. Now, if we look at this case that I proposed to you before, we know that these before and after cases do not happen by accident. There is a rhyme and a reason and a system that we have to follow. There are principles that dictate the type of bone that we achieve, with our techniques. So none of this happens by accident. None of it happens just by plugging bone into a hole. It's all about flap design, choosing the correct materials, timing, et cetera, and with that, we'll get to the meat of the presentation here. So as far as choosing a bone graft material, let's review for a second, what the 4 sources of bone are. Your first source, that's considered and classically studied is the autograft, and this is the type of bone graft material that comes from the patient's own body. It often comes from an intraoral site, such as the maxillary tuberosity. It can also come from the ramus or the chin. If we look into some of the classic studies as well, we can talk about iliac crest grafts as well as tibial grafts and things like that. Probably the most common and what we're going to be really touching on a lot today is going to be the allografts, which are basically divided into 2 categories. You can either have mineralized or demineralized bone. And allografts come from another human being. So the key thing with allografts is it's the transplantation of one tissue to another between two people of the same species, so person to person here. The third source of bone is a xenograft. This is what we would call animal bone. Okay, so the common sources or common animals that we use are going to be bovine or porcine or cow or pig type sources. And the fourth and final are going to be alloplasts. These are our synthetic grafts, such as calcium sulfate or bioactive glasses, ceramics, and things like that. But for the purposes of this webinar today, everything that you're going to see accomplished today is going to be accomplished with the allografts. Specifically, what we're going to be talking about is the mineralized freeze-dried bone. There's a lot of different choices that you guys have to consider when you're considering bone graft materials. It seems like every implant company and other companies have just a plethora of different bone graft materials and regenerative products that you can consider. And I was looking them up the other night and just came up with all these little abbreviations and acronyms for all the types of bone. I could see how if you're new to this or even experienced at this, it can be very, very confusing. As a matter of fact, I don't even know what half of this stuff stands for. So let's go through all this and see what you really, really need to be successful. I would say by far and away, one product that you can't do without, for me, is going to be the Mineros cortical bone from BioHorizons. It's going to be the workhorse product throughout this presentation. The other thing that you're going to need if you're going to be successful is some type of a collagen membrane. I prefer the resorbable type. We'll talk about Memlock and how it has some built-in advantages over some similar products in its class. But before we talk about the materials, let's talk about the principles of bone graft. What do you have to do? Okay, there's going to be rules on how bone grows, specifically how it grows in the extraction sockets. If we look at this article by Homley Wong, he talks about the PASS principle, which I think is an excellent paper just detailing, roughly the 4 principles that we have to have if we're going to be successful at grafting. So the first thing is primary closure and primary passive closure, more specifically. So you have to be able to suture and manage the soft tissue properly over the graft material if we're going to be successful. The second thing you're going to need is angiogenesis. We have to have a source of blood to obviously feed the bone graft material, to repopulate it with the regenerative cells that are necessary to grow new bone. That graft that we place for patients, we have to maintain the space around it, and that graft has to be stable. Obviously, if we're going to try to grow bone, we can't have that bone move around on us, and we can't have objects or other irritants pressing on our graft if we're going to convert that bone graft material into bone. For those of you who have been around a little bit longer, you guys will remember a paper or at least a presentation from Dr. Stuart Fromm, and he talks about the 4 S's of bone grafting, which is another way of summarizing the principles of bone grafting. And he says with the 4 S's that the first requirement is that you have to have a clean surface. So having a clean surface is very important, whether you're grafting around a tooth, grafting around an implant, inside an extraction socket, ridge, et cetera, et cetera. That surface that you're grafting to must be clean. Just like the previous paper, you have to have graft stability as well as space maintenance. Those two are imperative to the success of bone grafting. And the last thing here is submersion. So according to Dr. Fromm, the graft needs to be submerged. That's just another way of saying you have to have nice primary passive closure over your graft if you're going to be successful. Now, there are exceptions to every rule, and we'll talk about that briefly. Now, earlier I made the statement that socket grafts are probably going to be the most predictable bone grafts that any of us ever place. And that's a true statement. The reason that is because an extraction site is an acute wound. It also contains periodontal ligament cells, and it's also an excellent source of blood vessels for angiogenesis. Okay, so we've got that vessel that we need to promote bone growth. We have an oasis of growth factors in the periodontal ligament cells. But the key thing here really is that it's an acute wound. And why is that important? When I'm talking to patients about this, the example I always give them is let's just say you were in an accident and you lost a finger. Okay, if you want to have that finger replaced or reattached, the time to do that really is at the time of the amputation. So we got to get over to a surgeon immediately. If we decide to wait a week or a month or whatever, the chances go down significantly. So same thing here. As soon as we take a tooth out, if we decide to wait until the ridge is healed, number one, we know that the bone is going to rapidly disappear. But number two, it's no longer an acute wound, and we'll have to trying to grow bone will then be a much greater challenge than if we would have done that at the time of the tooth removal. So before we get started, let's talk about the basic socket grafting technique. Now, the basic socket grafting technique is the situation where you can take a tooth out, and if you do the proper bone analysis, you can actually just plug the hole with bone. However, that only tells part of the story, but let's review first. So this gentleman here, he presented to our office for tooth number 9, which had a horizontal root fracture here, obviously hopeless, and we decided to remove the tooth. As far as choosing the type of bone, we always choose mineralized cortical bone. Well, if you are in enough webinars or talks, presentations, etc., there's going to be some debate on what type of material, mineralized cortical bone or demineralized bone or cancellous bone, cortico-cancellous bone. There's all these different options. I'm here to tell you that the only thing that you really need, and I'm going to show you plenty of proof on this, is that the only thing you really need is mineralized cortical bone. You can use other things, but we choose mineralized cortical bone for a couple of reasons. One is the physical properties. It has a very nice consistency that's easily packed into a socket. Number two, it lasts a lot longer than demineralized bone. Why is that? I've outlined for you guys the basic stages of bone growth. Now, as soon as you put a bone graft in, or with any typical bone wound healing, it's going to go through 4 basic phases. The osteoclastic phase, which starts at week 1, followed by the osteoblastic phase, which is the bone building process at week 2. Then you'll have immature bone formation, which we call osteoid, at week 3, and then of course the bone graft will mature up to a year. Now, there are books and studies on all this, but this would be, if you had to summarize bone growth in one slide, this would be it. Now, the reason mineralized cortical bone lasts so long is because, well, it's mineralized, so it has to go through that entire osteoclastic phase from week 1, whereas demineralized bone, with it being demineralized already, is there's less need for osteoclastic activity, so it kind of starts at week 2, so it has a head start on the wound healing, and that's why mineralized cortical bone will last a little bit longer than the demineralized. With the size defect is a socket, it's probably more important that the bone stay around longer than it is for the supposed osteoinductive activity of the demineralized bone. When we look at the packaging on the mineralized cortical, the other things I like about it is the ideal particle size. So as you can see on the packaging, the particle size ranges from 300 to 1,000 microns. This particle size is very important because if you get below 250 microns, classic studies will show that the bone graft material is too quickly resorbed just because of the size. But if you get over 1,000 microns, or 1 millimeter in diameter of the particles, well, those size particles are so large that they often become fibrously encapsulated, so they don't turn into bone. So with the mineralized cortical, it has just the perfect amount of particle size. And you also want varying particle sizes as well to allow for proper fluid exchange between the host bone and the bone graft material. So going back to this gentleman here that had the horizontally fractured root on tooth number 9, the way that I like to take out teeth is it's not an arduous process, but it's certainly a slow, patient process. And the first thing that I do is I'll introduce the number 15 blade and make a cellular incision 360 degrees around the tooth. And then I'll also utilize that blade as a periotome on the mesial aspect as well as the distal aspects. And I'll introduce it into the periodontal ligament space rather firmly. And how firm? I'll basically will insert the tip of the number 15 blade into the PDL space with enough pressure to where my nail beds turn color, and I can actually let go of the handle and it will still stay in place. I do that for a few minutes on each side, the mesial and the distal aspects. as you can see here, and then after that I'll use a straight periotome and do the exact same thing. The only thing is I'll also walk the periotome once again rather firmly into the PDL space, but I'll also walk it along the palatal aspects as well, as you can see here. I never ever advocate the use of periotome or any other instrument on the labial aspect, because we want to preserve the labial plate as much as possible. As predictably observed here, you can see that the crown has been removed, but the root remains intact. This is due to the horizontal root fracture, so we basically repeat the processes that I just outlined for you. And eventually, once we get 270 degrees around the mesial, palatal, and distal aspects with this periotome, the remaining root will come out rather easily. When we evaluate the socket, you can see that we have two intact papilla. Here's the distal, and here's the mesial here. And from the facial, you can see that we preserve the scalloping quite nicely as well. At this point, because we have 4 walls of bone, our mineros is then hydrated, or has been pre-hydrated for about 20 minutes to get proper hydration and moisture of the bone graft materials, and then we just simply pack the bone into the socket. Now, you can only do it this way if you have 4 walls of bone, so you have to have a nice, thick labial, palatal, mesial, and distal wall. If we even have a thin wall, I still may consider the use of a membrane, which we'll talk about here in a second. But I use a simple cotton tip applicator to condense the graft. It's cheap and easy. The reason I like it is because it will absorb any excess moisture and blood while also packing the bone. After this, if you want to suture it, you can feel free to, but you don't necessarily have to, because for this first type of socket in which you have 4 intact walls of bone, you can simply place the bone graft material, in this case it's mineros, and go. You don't need primary closure. As far as provisionalization, we prefer an Essex retainer, but you can also use a single-tooth transitional partial denture as well. But generally speaking, most people prefer tooth-borne prosthetics to stay off the graft. There are 4 situations where you cannot do this basic socket grafting technique that I just talked to you about. The first one is when you have blown-out labial plates. If you do this, you will not have the graft stability, space maintenance, and epithelial exclusion that you will need to grow bone in that socket. Case number 2, or situation number 2, if a patient has severe periodontal disease, meaning in this situation she has severe recession, and radiographically we have bone loss all the way down to the apex, that we estimate probably, 90% plus bone loss. Remember, it's called ridge preservation graft, okay? So if there's no ridge to preserve, the simple take the tooth out and plug the hole with bone technique does not work at all in this situation. Situation number 3, if a patient has a periapical abscess or a clinical fistula present, like in this situation here, you cannot just take the tooth out and simply plug the hole with bone, okay? You may get a decent result for putting in an implant, but as far as cosmetics and optimizing your result, I think you'll fail at that in a predictable manner. The 4th situation is something that we've only considered primarily with the advent of CBCTs, is that some incisors don't have the bone to begin with. Like in the situation here, we've got a canine that we're going to remove, and you can already see that the buccal lingual dimensions of the root is already significantly wider than the buccal lingual dimensions of the bone that it sets in. So these are situations, and here's one for the lower incisor area, that we need to consider, is that some patients already have anatomical defects that we can't get around or need to augment at the time of the extraction. So now we've talked about having 4 intact walls of bone and how to treat that. So in that situation, to summarize, you would just simply put in your mineralized cortical bone into the socket, suture if you want to. Primary closure is not important, and you can move on. But let's just say we've got a fenestration or dehiscence now. So we will gradually throughout this talk start to remove more and more bone and discuss how to handle those situations. So let's say we have you take a tooth out and you have a small fenestration, 5 millimeters in diameter or less. How do you deal with that? So the typical situation where this would apply is like this. You've got a tooth number 8. You have a draining fistula present. The when you look at the gingival margins, they're uneven. So for me, there's two reasons why I would not do an immediate implant placement. Number one, I don't like the soft tissue levels. So I really want to get those level before we do anything. And number two, with draining fistula, we know that 100% of the time you're going to have a compromise in the labial plate. So we've got some bone loss on the labial aspect. So how do we manage this? On the other hand, we also get nervous about reflecting gigantic flaps on the facial surfaces in the aesthetic zone because we get concerned about how it heals. So I'm going to talk about our next technique, which we're going to call the ice cream cone technique, proposed by Dr. Dennis Tarnow, and I'm sure you guys are familiar with some of his work. But we may not always want to reflect a flap in a situation like this, okay? Because we worry about scarring, we worry about soft tissue healing, and of course, if we worry about those two things, we're going to worry about the final implant. So how do we get from a situation like this to a situation like that? Okay, let me show you. So once again, if you guys are interested in this technique, it's just under Dr. Dennis Tarnow. He calls it the ice cream cone technique, and it's a great way, as a matter of fact, to treat fenestrations and adhesions. So let me talk to you about this young lady here. Tooth number 8. We have quite a bit of soft tissue swelling on the facial side here. And then radiographically, you can see that endodontic treatment was initiated but not completed. We have internal resorption, and once we took the tooth out, that was the plan. You can see where we've got some soft tissue extravasation out into the labial space there. So there was actually no bone, but fortunately for her, it was a small fenestration. So in a situation like this, we're going to have to introduce the concept of using a membrane for epithelial exclusion, space maintenance, and graft stability. So what you do is you grab a piece of Memlock and you trim it. You're supposed to trim it like an ice cream cone, but every now and then I get a little bit lazy, so I kind of trim it more, like what you see here. All you do is you trim it roughly to the dimensions of the socket. You place it into the socket and adapt it up against the labial wall, okay, as you can see here. Now, one thing I want to note is this membrane is placed into the socket. It is not placed between the soft tissue and the bone. It's just simply placed into the socket. And then in this situation, we're also using mineralized cortical bone. That seems to work the best. We condense it to the labial aspect here, and then we simply fold over the ice cream portion of the ice cream cone membrane, and then we suture it. Okay. Now, once again, you do not need primary closure, fortunately. And the reason you don't is because you already have adequate graft stability, adequate space maintenance. So we don't really need, we have epithelial exclusion from the use of the membrane, so we don't really need anything else here. If we look at it 3 months on a 3-month reentry, you'll notice that we have just a massive amount of bone in which to place an implant. Now, I don't typically reflect flaps like this at the time of implant placement, but I did that for the purposes of today so we can show you how much bone we have. Now, after the implant is placed, what a lot of people tend to do is they get excited about putting the implant in the right position, and then they go straight from removing the healing abutment to the final impression to the final prosthesis, and oftentimes they're disappointed with the results. So I'm going to show you guys a few slides on how I will train the soft tissue to sculpt the way I want to. So in this situation, the restorative dentist had placed a provisional that I wasn't completely happy with because the distal line angle on the central incisor was a little bit too rounded. And if we study our tooth morphology, we know that the distal line angle needs to be more straight. So this is a way that we can help our restorative dentist out very easily. All we do is we take off the provisional restoration, get a little bit of flowable composite, and we add it to that distal line angle. What that's going to do when we re-cement it is it's going to push that tissue out. Okay, now this is about a week to 2 weeks later here where we've pushed that tissue out, and maybe I straightened that distal angle out a little bit too much, but you can get my point here. We let the soft tissue heal, and now it's still pink and healthy. We can convert the patient over from a provisional restoration to the final, which I will show you momentarily. But here you can see the first provisional with the rounded distal line angle, and then after the modification that we did chair side, you can see the difference in the size and shape of the papilla just by manipulating the provisional restoration. And then, of course, the final restoration a couple of years later. This is actually at 2 years now. So this is just how we can manage anterior cases a little bit better with provisional restorations. Now, now we're up to our third technique here. So the first one was your four-walled socket, in which case you just graft you just place the bone into the socket, suture it if you want to, and then move on. Technique number 2, we utilize the ice cream cone membrane to patch a dehiscence or a fenestration of 5 millimeters in diameter or less. Neither one of those required the use of the achievement of primary closure with our suturing. Now we're going to introduce some more complex cases. So for this third one here, we're going to talk about blown out buccal plates. Okay, and blown out, what I mean by blown out is we don't have any labial or buccal bone after the removal of the tooth. GBR or membranes here are highly recommended. In fact, I'm just going to say that they're just imperative to our success. So if we look at this tooth here, number 7, we can see that we've got a draining fistula. We also see pathologic migration of the tooth from periodontal loss of support. Radiographically, there's even a supernumerary tooth at the apex, and you can see all the bone loss that surrounds the tooth, as well as internal and external resorption. So the tooth clearly needs to be extracted. The challenges, though, are far and wide. For instance, we have the periapical pathology, which always indicates labial bone loss. We notice that we have a periodontal abscess, and obviously with a periapical pathology, we have a blown out labial plate. We can pretty much diagnose this before we even take the tooth out, just from what we see clinically. So how do we manage blown out buccal plates? So in this situation, let's talk about the first thing you want to do is remove the tooth as atraumatically as possible. As far as flap designs go, in the aesthetic zone, one thing that you want to avoid is, if you like the size and shape of the papilla, try not to incise through the papilla. So here we've kept the papilla intact. There's going to be some debate there on whether a flap design or a flap at all is necessary, and I can honor and respect that. But for the majority of people who are unfamiliar with bone grafting or are new to it, this is going to be the most predictable technique for you. So after the tooth is removed, here's the supernumerary tooth that's been removed. What you're going to see is we have full thickness flap reflection, so you can see the bone. There's no soft tissue or connective tissue attached to the bone here. Now this tooth has been in this condition for so long that even though we just took out the tooth, we don't see any bleeding. So remember earlier I talked to you guys about the value of having an acute wound and proper bone grafting or successful bone grafting. So one way to recreate an acute wound is to get a round burr, and I prefer usually a number 2 or a number 4 round burr. Carbides are okay, but I like diamonds just because they tend to not grab the bone, and they're very much more precise generally. But at any rate, you want to use a high-speed number 2 or number 4 round burr, and you basically penetrate the cortex of the bone. We call them cortical perforations, and what that does is just causes the site to bleed. Remember, we need angiogenesis, or we need a source of blood vessels in order to get bone growth. So there's 3 concepts here: once the tooth is out and once the cortical perforations have been made. The first thing we're going to do is we're going to place our bone graft utilizing a concept called barrier by bulk. The second thing we're going to do is utilize a membrane to take advantage of the concept of guided bone or guided tissue regeneration. So the first one, after the tooth is out and you've done the cortical perforations, we're going to put the bone graft material into the socket, of course. Okay, and that's what we have to do to consider it a socket graft. But in order to consider this barrier by bulk, what we do is we put the bone graft material on the outside of the labial plate as well. Now this is important because we don't really necessarily think that we're going to grow bone on the outside of the labial wall. It's important to get a nice bulk or a nice mass of graft material there in order to help prevent the migration of the epithelium into the site of the bone where we really need it for our implant. The second thing that we need to do is to place our MemLock resorbable collagen membrane over the site. So here what we try to do is we trim the membrane such that it covers the bone graft material. But we also want the edges, if at all possible, to be over the host bone. And as you can see here, it folds over quite nicely, and it is woven pretty tightly to prevent epithelial migration, but also it's not woven so tight to where you don't have good fluid exchange. So once the bone graft and the membrane is placed, the key thing here is to get good primary passive closure, as you can see here. This is at 2 weeks out, and you can see how wonderful the soft tissue response is to the graft material as well as the membrane underneath. And then if we look at the occlusal view, you can see the dimensions of the buccal lingually of the ridge. Radiographically, it looks good from a periapical film, but if you look at it from 6 months on the CBCT, you'll notice here that we have full preservation of that ridge to where we can actually place an implant rather easily. Obviously, where we did the barrier by bulk, where we added the bone on the outside of the ridge, that part of the bone is gone. But we used it more to retard the migration of the epithelium more so than actually thinking we were going to grow the bone. So we look at this again. We took out tooth number 9 on this gentleman, and you can see why. But when we did that, we obviously can see that we have no labial bone here. So with the central incisor this size, we thought it would be intelligent to not include the papilla in our flap design. We added the bone graft as well as our resorbable collagen membrane here. Fold that over, and once again we get primary closure. This case is now going on 11 years old, and by doing so, we can actually get us a final result with a dental implant and a single tooth prosthesis here. That's very, very, I wouldn't say it's just perfect. Obviously, you can see some scar lines, but it's very acceptable, especially when you consider his tissue biotype as well as the size of his central incisors, which are rather large. So the basic rule when we're talking about bone grafting surgery is that if you don't have a facial plate when you take a tooth out, you want to use a membrane. So in a situation like this, you take the tooth out. Yeah, I mean, there's still like a thin isthmus of bone here, but the large majority of it you would consider missing. The bone is placed into the socket, and we place the membrane. Once again, you want to trim it such that when you suture it, you don't want to see any of the membrane exposed. So here, where the membrane is covering the bone and the edges of it, ideally are going to be over host bone. It's not imperative, but it is ideal. Primary closure is achieved when we do our surgical reentry. This is at 6 months later. Our surgical reentry, you'll see that the fenestration has been filled with bone, and that is just a more than adequate quantity of bone for implant placement. And we'll just go through several of these here. So this young lady, she actually came to our office because she was interested in implants to replace congenitally missing number 7 and number 10. Situation that we see a lot. But during our clinical exam, I noticed that we've got a little fistulous tract right here. So I was curious a bit about that, so we obtained a periapical film. You can see a periapical radiolucency here. And on the CBCT, this is the sagittal view here. You can see just a large defect around the apex of that tooth and virtually no labial bone here. We were concerned about that. We sent her to the endodontist. They ultimately recommended an extraction. So in the same manner and design that I've showed you before, we took the tooth out, exposing a very large fenestration here. So what we chose to do is graft the socket with mineralized cortical bone. And once again, when you're doing this with full thickness flap reflection, you want to put your bone graft material into the socket as well as around the labial edge there, labial wall. There's our resorbable collagen membrane placed. Passive primary closure. This is what the site looked like at 3 months, and then we obtained a new CBCT at approximately 4 months, and we can see how dense that mineralized cortical bone is. It almost looks like another rudous form. But here's the before, and here's our after. This is on the software we're using here is just the virtual implant placement, and then we later went over to anatomage to look at it here. But you can see here, even from the this image, how dense the bone is, and then the surgical reentry. While there are a few of the mineral particles left, the large majority of it has integrated, and you can see just a massive amount of bone. Compare it to the congenitally missing lateral side here. We have just a quite amount of bone regenerated, both in the not only preserved but even regenerated to the labial aspect here. This gentleman here, so we're going to talk about severely blown out facial and lingual plates in this case. So this gentleman came to us with failing root canal therapy, asymptomatic, but his wife is a dental hygienist, and we noticed a large periapical lesion there. Have blown out facial and lingual plates. You can see it's a through and through defect. So just like we've showed you before, you're going to add your mineralized cortical bone into and around the socket. Here's your membrane over the top of that. Primary closure is imperative once again. And that's your 2-week checkup here. At the 2-week post-op, suture removals are done, and hopefully the soft tissue looks like it does here. Now, you guys will notice during the course of that surgery that we forgot to put a membrane on the lingual aspect, and that's, of course, is why you see a defect here on the lingual side, whereas where we put the bone on the labial side, it looks very large and intact. This is the CBCT software that we're utilizing here to show that that defect has been filled, and there's our 6-month reentry. You can see that not only did we preserve the ridge, but we even added quite a bit of labial bulk, and there's the final implant and restoration there. So if we look at blown out implant sockets, same thing. You know, you approach it the same exact way. The only difference is you don't have a periodontal ligament to take advantage of as far as the growth factors and such go. So if we look at 2008, this is 6 years old now. This implant has begun to fail. We talked to the gentleman about removing it and regrafting and replacing it with an implant. His primary care doctor places his own implant, so he was referred simply for the bone grafting portion of this. So this is what he looks like clinically. Quite a bit of recession. Patient is not concerned about aesthetics at all, which is good. So we were just worried about growing enough bone to replace the tooth with an implant. So here we have the implant condition upon full thickness flap reflection. My concern is that when we took the implant out, and you can see why we took it out, you can literally see some of the osteotomy was placed into the adjacent tooth. Matter of fact, if we go through some of these photos, the central incisor literally appears to just be floating in space here, as you can see. Patient chose not to have number 9 removed, so we chose to deal with what he was presenting to us. So we created an acute wound, as you can see here, with a diamond round burrs. Continued to degranulate the socket as well as tooth number 9. Referred tooth number 9 to an endodontist for evaluation and treatment. Patient still did not want to extract number 9, so we proceeded with our barrier by bulk, adding bone into the socket as well as around it, followed by our Memlock membrane. We got primary closure naturally. Now, when we took a final PA, because we use mineralized cortical bone, it always looks good on a dental, traditional dental film. We always have to get a CBCT of the area here, and what I want to show you, I thought was pretty neat. Here is that slice that I'm going to show you right here. So directly through that slice, you can see that we have now about 6 millimeters of buccolingual ridge width to replace that lateral incisor. Like I said, after that, I lost track of the patient until I saw him in a cafe recently, just last year, and he allowed me to he agreed to come into the office to take a photo. Cosmetically, I didn't like what I saw, but I was surprised pleasantly that following root canal therapy, he was able to keep number 9. And number 10, when you look at the film here, his new dentist, his old dentist replaced that implant with a implant that we can talk about appropriate implant sizes and such. But long story short, he was able to place a implant that was wider than 4 millimeters in diameter into that previously failed implant site. So if we look at other implant failures, this is one of my own. This is a family friend of mine, so naturally we're going to proceed with caution and expect failures on occasion. It kind of seems to be Murphy's Law in these types of cases. So we have number 19 and 20. What we did, because she was a family friend, we decided to stage her approach. Like it was just a very classic two-stage, two-stage implant approach. Placed the implants, put cover screws on, got primary closure over the cover screws. I always take a routine radiograph at 8 weeks, and this is what we saw. We saw a radiolucency surrounding both implants. I was immediately concerned and suggested removing the implants. With her situation, she did not want to do that without knowing what we were going to do differently. So when we took out the teeth, we didn't do anything that I did not present to you already. We grafted the site with mineralized cortical bone. We used a resorbable collagen membrane. So she was wondering what we were going to do differently. And so for the first time, and this is also back in 2005, 2006, when we removed these implants, we noted that we had a blown out lingual plate on the tooth number 19 implant, and then on the tooth 20 implant, we had a blown out labial plate. And what I noticed, what I chose to do differently, is to use a demineralized bone putty, or the Grafton's DBM putty. That was my solution to Deanie as to what we were going to do different. Now, would I do this again today? Probably not, and I'll share with you how I would do it today. But back then, we decided to graft the sites with the DBM putty, and then instead of using the Mentlock collagen membrane, what we decided to do was use the Alloderm GBR as a membrane, and that's what you're seeing here. Okay, so you're seeing the Alloderm GBR soft tissue allograft as a membrane with the DBM from Grafton underneath. This is what the radiograph looks like at 6 months. I was actually pretty impressed with this because with that DBM putty, it's demineralized bone, so radiographically it really shouldn't show up. And then when you look at it clinically, you can see that, oh my gosh, there's plenty of bone, both on the labial dehiscence that was present has been repaired. The lingual dehiscence on the other side has also been repaired. So we were ready to start over and get her the result that she needed. So if we're talking about acellular dermal grafts as a substitute for the collagen membranes, you can use that. It's not a very popular choice, but I do want to share with you that you can do that, and that's why I showed you this case. It's a really good situation to use that whenever you take a tooth out or you're going to augment a ridge and you need a membrane. It's nice that we have the acellular dermal grafts like Alloderm to double as a membrane, but you can also use it to thicken the tissue because it is a dermal graft material. And it's been reported in implant dentistry as late as 2005. So if we look at ridge augmentations, this is a common case that you'll see, and I know I'm getting ready to run out of time with you guys, so I'm going to speed up here. We have a bridge that was on number 18 through 20. The ridge ponic site, number 19, is obviously very, very deficient in bone, which is why you see the ponic showing up here on the CBCT. If we replace the implant, it would come out the lingual cusp here, so it would be in the wrong position. So we talked to the patient about doing a ridge augmentation at the time of extraction of the tooth number 18, and that will allow us to place the implant in a more proper position. So here we're going to flash forward to this slide. We've got tooth number 18 with the tooth missing, and then in the 19th side you can obviously see the large deformation here. So just like with any ridge augmentation, the first step is to create an acute wound. And you do that by placing cortical perforations with a number 2 or number 4 round burr. Once again, I prefer diamonds. This is mineralized cortical bone. That's my favorite. And then in this situation here, we just used, if you're going to use an acellular dermal graft, Alloderm, for me, I always just use the Alloderm GBR if we're going to use it as a membrane. have to get primary closure, and at 6 months, you'll notice that here's your host bone and here's the grafted bone. It's very, it is distinguishable, but very, very, it's close. So we do it another time, and I'm just going to go over this just to show you guys this stuff works. Here we've opened up the area with a full thickness flap. Have quite a bit of a buccal ridge atrophy here. You got to convert a chronic wound or a chronic site into and create an acute wound by utilizing those cortical perforations. In this situation, remember the principles of bone grafting. You also need stability and space maintenance of the graft. So in this situation, I chose to use a tenting screw, which is also available through BioHorizons as well. We utilized one tenting screw, and then we placed our Mineros around the screw, followed by 2 membranes for the size of defects. And once again, you have to have submersion of the graft or primary passive closure. Now, if you pull the mucosa up over the site, that is fine. You can always deal with that later, but the important thing is to get good closure. This is what the site looked like at 2 weeks, and this is our 6-month reentry with the tenting screw out. So you can clearly see how much bone we were able to grow for this patient to accommodate her implants. We've only got 2 more, and then we'll be done here. As far as this situation where we have a combination of socket grafts as well as a ridge augmentation, this gentleman's fractured number 6 and number 9 at the gum line, gingival margin here. Both teeth are non-restorable. We decided to do a basic socket graft for these 2 extraction sites and then augment the ridge here. So once again, you got to do cortical perforations in this chronic site here where the ridges has been edentulous for quite a long time. And then for these, with the 4 walls of intact bone, you're just going to place your mineralized cortical bone into the sockets. So here, what we actually ended up using, I said earlier that I would not use just the graft-on putty as my sole graft material. The reason why is because the carrier, tends to cause the bone to lose its physical dimensions rather rapidly. You lose the space maintenance and stability rather quickly, which can compromise your final result and lead to ultimate failure. So if you like to use the DBM putty from graft-on, what I do now is I'll actually mix my Mineros with my graft-on and use that as a composite graft, and I'll layer it over the ridge defect. What that does is it allows you to take advantage of the osteoinductive properties of the putty combined with the physical properties of the cortical bone. Here we're just using our membrane. In this situation, I probably could have cut one a little bit bigger, but for whatever reason we didn't that day. Primary closure is still paramount to the success of this procedure. This is what it looked like at 2 weeks. This is the facial view. This is the surgical reentry. I love to show you guys surgical reentries because I don't feel like enough people do that for you. But here's the after. Here's the where we started, and there's where we ended. Our last one here, we've got a patient, another friend of mine. She decided she was tired of wearing her removable partial denture. Problem is she never considered implants because she's been told that she was not a candidate because of her low sinus. So our treatment plan for her was to do a lateral window sinus graft combined with removal of this hopeless tooth number 10 due to non-restorable recurrent caries. And then we were also going to do a ridge augmentation in the canine premolar area. So let's walk you through that. So for tooth number 10, we simply removed it, left the labial wall intact. Here you can see how thin the buccal ridge is for the canine and premolar area, as well as the molar area. Here's our lateral window that we utilize here. We now use different techniques for our lateral window, but here we just use the good old-fashioned number 6 round burr. We infracture the window to where the lateral wall now becomes the floor. Membrane, the sinus Schneiderian membrane is left intact. We place a piece of collagen sponge as our most superior layer, followed by our graft-on putty is our second layer, and then our last layer is just going to be mineralized cortical bone. With the cortical perforations, what we're aiming for there is to establish some bleeding points to feed our graft. Here you can see at the at the crustal ridge area, how thin that bone is. You can almost flake it off with a scaler. Then we layer our mineralized cortical bone along the labial aspect. And then here we use that thin acellular dermal graft. So always use that thin GBR version if you're going to use it as a membrane here. Then we have primary passive closure. So this is what I loved about these procedures is they're very, very predictable, and there's a system to it. So 6 months after augmentation, you can see that we've got plenty of bone in the sinus area. But the cool thing is whenever I show you the re-entry here at the time of implant placement, you can see how wide that ridge is. Those pilot holes are for the initial osteotomies are 2 millimeters in diameter. There's your before and there's your after. So the bottom line, as we wrap things up, is that every socket is different. I hope you guys can see how we've managed different situations utilizing different protocols, and they were treated differently. So to summarize, I put together this little table. So the two questions are always, when do I need a membrane, and when do I need to get primary closure when I suture? So to summarize, 4-walled sockets, take out a tooth, you have 4 walls of bone, labial, lingual, mesial, and distal. You don't need a membrane. You don't need to get primary closure. If you have a 5 millimeter fenestration in the labial wall or lingual wall, you do need a membrane, but you can utilize that ice cream cone shape membrane, but you do not need to have primary closure. And lastly, if with walls that have 3 walls or less, so with blown out facial plates and even ridge augmentations, you have to use a collagen membrane and you have to have primary closure. And remember, it's not just primary closure. You have to have primary passive closure. Finally, the recipe for everything that I showed you guys in this hour's webinar was done with 4 different products. For bone, we use 2. We use mineralized cortical bone from Mineros, and then we use the graft-on putty, DBM putty. The 2 types of membranes that I showed you today was the Memlock resorbable collagen membrane, and then I showed you the Alloderm GBR as our second membrane that we used. Once again, we use the mineralized cortical bone. We use Mineros cortical because of the particle size, but also because of its superior physical qualities. It stays around long enough to grow bone in large defects such as extraction sites, ridge, and sinus augmentations. As far as the graft-on DBM putty, number one, it's been shown in studies to have osteoinductive potential. It's very easy to use. It's in a nice glycerin carrier that offers up superior handling ability, and also is utilized very effectively in extraction sites and ridge and sinus augmentations, especially when you combine it with a particulate such as the Mineros cortical. The Memlock membrane, there's a lot of collagen membranes out there, and there's a lot of resorbable collagen membranes out there. The key thing that you want to look for is a long resorption time. So the minimum that's recommended by me is something that lasts at least 4 months. Memlock lasts 26 to 38 weeks, which is plenty. You also want something that's strong, so it's got a high suture pull-out strength. So it's got to be strong, and it's got to be tightly woven. But it also can't be so tightly woven that it seals out fluid exchange. If it seals out fluid exchange, then you can get flap necrosis and poorly exchange of fluids and growth factors for bone growth. So Memlock has the perfect combination of both physical properties, strength, and porous, but not being too porous. With that, I'm going to open up our talk to questions here. Just use the chat box on your screen. Type them in. I'll read them out loud and respond promptly.
Yeah, just to reiterate, everyone, if you'd like to ask a question, there is a question panel in your window that you can type in your question, and Dr. Wong will answer those. Thank you. Okay, Dr. Wong, we've got some questions coming in here. I'll go ahead and read them out to you if you don't mind answering for us.
Okay.
First question is from Adam Toller. What is your favorite way to release a flap to obtain primary closure?
Okay, yeah, that's probably one of the most common questions, Adam. To release a flap, I mean, that is probably, if I had to single out the most important skill set that a surgeon needs for bone grafting and implant placement, that would be it. You got to learn how to release a flap. The best way for me, and you know, we can certainly post more videos on the BioHorizons website to show you guys this. But what I do is I just take a simple cotton plier, and I will actually pull the flap back. And the first thing that most people tend to do is they'll tend to get a really sharp 15 blade, and they'll keep going more apically, and they'll keep making the vertical incisions longer and longer and longer. And you can't do that. Okay, that actually, number one, it's ineffective, but number two, you may hurt somebody as far as hitting important anatomical structures. So the thing that you want to do is once you have your flap reflected, you get a pair of cotton pliers, you pull it out to the labial. So what you're doing now is looking at the labial ridge. The first thing you want to do is check the most apical portion of your vertical incisions. So right at the junction where the flap, where your vertical incision stops and the flap starts. Look right there. You're going to see some soft tissue fibers. You want to take a nice sharp 15 blade and you want to release those and make sure that you cut right through those very gently. The second thing you want to do is on the flap side, on the connective tissue side on the flap, you'll also see some fibers there, and you'll gently, in what we call an accordion style incisions, you'll make very, very small periosteal incisions, and that's why we call them a periosteal release. But I tend to use a sharp 15 blade, and you'll see these little muscle or elastic fibers on the connective tissue side of your flap, and you'll start at the most coronal aspect of your flap and then work your way down towards the apex of your flap. But you want to be careful of certain anatomical structures. Right off the top of my head, I'm thinking you want to avoid the middle foramen, facial arteries, and things like that. So just be approach with caution, and that's why we always advocate starting at the crystal part of your flap and working your way down until you get enough release. The second way is using those Metzenbaum scissors. That works as well. It's certainly safer, but people tend to have a more difficult time getting the flap released that way. So hope that answers it.
Okay. The next question is, how tight is too tight when packing bone?
Okay. So when packing bone, the thing is there's always a question: is tight and too tight? And a lot of times the origin of that question is this. If you pack it too tight, then you risk crunching all the particles together to where you can't get any blood, you can't get any fluid exchange for all the nutrients needed to feed the graft. And then on the other hand, if you don't pack it enough, then you risk getting soft tissue or losing graft stability and space maintenance. So how tight is too tight? The thing is you want it all full, and then I gently pack it. If we're talking about a 4-walled socket, too tight to me would be if your nail beds are turning colors while you're packing it, that's too tight for me. Okay. Fortunately, you have a built-in safety mechanism with the Mineros cortical. You'll notice on the packaging it's a particle size of 300 to 1,000 microns. They do that on purpose. They don't make them all 300 microns because the joy of having variations in the size is from 300 to 1,000 is that there's going to be built-in spaces. Okay, so you don't have to be too particular about it. But too tight generally would be if your nail beds are blanching or turning colors, you're probably packing it too tight.
Okay, next question: what suture material do you suggest?
Yep, thank you. So suture material is another thing we didn't have time to touch on, but I will right now. So the two things the two that we generally try to avoid: we don't want to use chromic gut suture. People like it because it's resorbable, but as clinicians, we hate it because, depending on patients' saliva, the pH of their mouth, et cetera, a lot of times it'll come out too early. Okay, so don't use chromic gut or anything resorbable. Second thing you don't want to use is silk suture. Okay, silk is fine. It seems like it's the most commonly stocked suture, but you don't want to use it because it will tend to trap bacteria or wig bacteria and cause some localized infections or at least some inflammation, which can affect the soft tissue closure, et cetera, et cetera. For me, there's two that I'd recommend. I would use a either Vicryl, and as far as the size, depending on the size, on your comfort, my favorite suture is going to be a 5/0 Vicryl suture on a P3 needle. If I had to pick a second, it would just be any type of a nylon suture. Third would be something like Gore-Tex. But my favorite by far is going to be a 5/0 Vicryl suture on a P3 needle.
Alrighty. When do you use a block graft instead of a particulate graft?
Yep. Okay, so how to analyze that? So generally speaking, if you're talking about extraction sites, the focus of this webinar is mainly socket graft management. For most, I would say almost all socket grafts, we pretty much get the results that I showed you today with only particulate grafts and resorbable membranes. Now, there's going to be different opinions out there on, when you use titanium membranes and when you use, block grafts. Block grafts are more or less reserved for dentulous ridges that need 4 millimeters of bone, talking about ridge width or more. So if you have a healed ridge and a dentulous ridge where you're going to need more than 4 millimeters or more of bone, you pretty much have to consider a block graft. Some people will say if you need 3 millimeters or more of bone, you need to consider a block graft. But generally speaking, I would say 4 or more millimeters. Then you're going to, if you need 4 or more millimeters, you need a block graft. But for any extraction site, you should be able to manage it just perfectly effectively with a particulate graft.
Okay. What technique are you using to eliminate infection in a graft site?
Yeah, so there's a couple different ways. For the most part, we like to follow Dr. Carl Misch's protocol, where you start the patient on antibiotics 1 to 2 days before the procedure, so that always helps. The second thing also is in situations like socket grafts, we don't mix our grafts with any type of antibiotic, but with sinus grafts and our larger ridge augmentations, we'll actually mix in clindamycin with our graft material. But I would say typically for an extraction socket, outside of placing the patient on antibiotics a day before, we really don't do anything else.
Alrighty, and would you ever use cortical and cancellous mixed mineros?
Yep, you can. Now the benefit of that would be, taking advantages of some of the growth, factor potential of the cancellous bone. With it being the marrow, coming from the marrow spaces, the idea is that you're going to have a wider use of the growth factors and to be able to take advantage of those properties. Now, for me personally, I just like the cortical, and that's what I've stuck with. But some people like the idea of having more growth factors, more growth potential in the cancellous. So either one I think is acceptable, but personally for me, I like the cortical solely by itself.
Okay. What type of bone is usually generated, and what is the optimum time to place implants after the graft?
Okay, so and now I'm not sure what type of graft you guys are talking about as far as if we're talking about interstitial bone or that type of thing. But the type of bone that's regenerated is the patient's host bone. Okay, so it's not like you're really growing the bone, and we can talk about that in a different webinar if you guys like. But the type of bone that results is the patient's own bone. If you take a core sample of it, it's host bone. Okay, there's no, it's not that the graft itself, the graft particles itself do not turn into bone. As far as when do you re-enter for the implant, if we're talking about a 4-walled socket or the socket where you have a fenestration of 5 millimeters or less, the first two cases that we talked about today, I will go in at 8 to 12 weeks to put the implant in. If we're talking about a ridge augmentation where we're treating the blown-out labial plate, or if we're just growing bone from scratch because we just augmented in a dentulous ridge, we usually go 4 to 6 months. And I would say if you had to err, I would wait 6 months.
Okay. With the ice cream cone technique example, it didn't look like you raised a flap. Did you relieve the facial gingiva to place the membrane over the top of the facial bone, or did it go on the lingual aspect of the facial plate?
Yep, that's an excellent question. The no flap is raised at all. for one, and so no flap is raised at all. And as far as the placement of the membrane, it goes into the socket on the lingual of the facial plate. It does not go between the soft tissue and the bone. Although that's not wrong to do that, it's just a long, tedious process. The way that it's commonly performed is to place the ice cream cone into the socket, lingual on the lingual aspect of the facial plate.
Okay. For socket grafting, when all walls are present, did you say that it is not necessary to use a membrane or sutures? In that case, how do you prevent losing the bone graft you just placed?
Okay. So in that situation, so if you have 4 walls of bone, we don't put a membrane down there. Now, part of that's going to be, once again, every clinician does it a little bit different. But if we're talking about evidence-based, papers, research does not support the need in all cases to put a membrane in when utilizing a socket graft for 4 walls of bone. The question commonly is, well, how do you keep it in there? Well, during the wound healing phase, it's just like, whenever you take a tooth out and don't graft at all. You just place a gauze pack in the patient's mouth and they're going to heal. And the reason they heal is because you have a clot formation within the hour. So typically, by the time you have a blood clot that forms into the socket, with the graft in it, that should suffice as far as keeping the bone in. Now, if that gets you nervous and you feel like you need a membrane, by all means do it. But another alternative to consider would be using like a piece of gel foam or some type of a cellulose type material to cover the graft site instead of having to break out a membrane. One would be cost, trying to manage costs for your office and also for the patient. We're not always out here to try to take out a tooth and graft a socket for $1,800, $2,000. Cost does play a role in some of these procedures. So I have found that just placing the graft and taking advantage of just the natural blood clot is good enough to keep it in. Don't forget the patient will also have an Essex retainer in as well. But if it makes you nervous, I would use a cellulose material like a gel foam or some similar type product over a collagen membrane.
Alrighty, and just a clarification from one of the doctors who asked a question regarding what type of bone is usually generated. He was referring to the density, so 1, 2, 3, or 4 of the bone that's usually generated.
Thank you. Okay, it's typically going to be a combination of D2 and D3 bone.
Alrighty, next question. What pain medications do you typically prescribe?
Pain medications, most of our patients, the large majority of them, are just going to be on hydrocodone 5.0 or 7.5s with a 325 milligrams of acetaminophen. But I would say the majority of our patients are switching over to ibuprofen generally after about on day 2 or day 3.
And post-op instructions, post-op care instructions.
Okay, so post-op care instructions. The biggest thing is keeping it clean. What we use, our patients typically will go with a chlorhexidine rinse to manage bacterial and the bacteria and keeping their mouth clean, because we don't want them to obviously brush the gum line where we just operated. We don't want them to brush around the sutures. We don't really want them to brush the adjacent surfaces of the teeth. Because we don't want them to pull anything or disturb the graft. Remember, graft stability and graft space maintenance is very, very important. The key thing here is, as far as like eating and that type of thing, we want to keep their food relatively soft, so we keep them on, like rotisserie chicken or ground meat, a lot of, very well-cooked vegetables, soft roots and things like that. Seafood's also a good choice, as well as pasta. We don't have them brush the adjacent area, but I have them brush normally on the adjacent teeth, on the other teeth. They can floss their other teeth that we didn't work on just fine. The chlorhexidine rinse is prescribed 1 bottle and to use twice a day. We obviously tell them not to smoke, not to use any smokeless tobacco, and basically not to use any force on top of the ridge that we just grafted. That is pretty much it as far as post-op goes. And we'll see them at 2 weeks for suture removals. And then we'll also see them just for a routine follow-up at about 6 to 8 weeks following the surgery, and then we'll plan the implant, at that 6-week post-op visit.
Okay, next question. If on the post-op visit for a 4-walled graft you see bone particles you can rinse out, what do you think happened there, and how do you prevent that?
Yeah, that's just bone turnover. So, when we were talking about the stages of bone, formation, you'll get bone maturation from the time of osteoid formation at 3 weeks all the way up to a year, and some studies will say even then some. That's normal. That's not to say that the graft failed or anything like that. That's just the patient's physiology. So that's not an indication of a failure on the graft side, the clinician side, or the patient. That's just bone turnover. If we were to wait, long enough, then yeah, I mean it would all turn into bone. But we don't want patients to have to wait 12 months or 18 months to have their implant. So the answer to the question really is, nothing happened. It's just still normal.
Okay, we have another post-op instruction question.
Okay.
Do you routinely place patients on antibiotics for the full week after bone grafting and implant placement?
Yeah, we typically do, and that's more of a practice management situation than anything else. We have found that when we do that, we have less reported post-op complications. Whether or not that's really due to the antibiotic or to a placebo effect, I'm not really sure. But we actually have just way fewer post-op complications whenever we put the patient on antibiotics for the full 10 days. We actually use amoxicillin 500 milligrams 3 times a day for 10 days, and we start them the day before. So that's cut down on our post-op visits.
Okay, what kind of bone do you prefer for this therapy, and what type works better?
The type of bone, no matter whose brand you use, mineralized cortical bone is the best for sockets. It's not only my opinion, but if you look at everybody on the podium speaking about socket graft management, the large majority at this point are advocating, mineralized cortical bone. Obviously we can have another talk on growth factors and all this other stuff too, which are very, very important as well for other types of situations. But for socket grafts, which is what we're talking about today, mineralized cortical bone is the best. And for me, the Mineros is about as far as like a final result, as far as the reentry goes, that's about as close to the looking and feeling like the host bone as you'll get out of an allograft. So my answer is Mineros cortical.
Okay, we actually did have a question on biologics. Do you use any sort of Endogain or PDGF?
Yeah, so we don't use Endogain because the main reason is just from the research that suggests that things like Endogain, while offering up superior handling characteristics, it actually does very little for growing more bone. So we don't use that, especially when you consider the cost. The cost versus benefit for something like Endogain is not there. As far as the platelet-derived growth factors and things like that, or if you look at platelet-rich growth factors and all that other stuff, I think those are really, really important, and those are nice aids for people to use. I haven't found them to be necessary in any of the cases that I just showed you all, but they're becoming a larger and larger part of everybody's practice. So if I had to pick between using Endogain or PRGF or PRF, I would stick with the PRGF or PRF because whenever you're looking at cost per use per patient, that's going to give you the biggest bang for the buck. And if we're kind of new to bone grafting, it does offer a nice clinical advantage for you.
Okay. What are the indications of failed bone graft, and what do you do when that happens?
Yeah, so failed bone graft, one of the most common things that you're going to see, unfortunately, some people don't know it until they go in for their reentry, and then they're surprised and having to face the patient with an awkward conversation about what happened and why and what to do next, because it is a long process. So indications that a graft may be failing. One is when you do your 2-week post-op, if you see like a rather large incision line opening, with any purulence or any exudate. That's commonly a problem. If you're doing especially if you're doing a ridge augmentation, or if you just managed a blown out buccal plate. It's less of a problem, if you're dealing with 4 walls of bone. So, I mean, it takes a pretty big infection to actually destroy a whole wall of bone in a matter of 2 weeks. So, I'm not concerned about those. But for those of you who are doing ridge augmentations or managing blown out plates, the biggest thing is going to be, a large incision line opening and any purulence or exudate. The second thing is going to be patient symptoms. They're saying, patients should really be comfortable by about a week, and no longer than 10 days. So if you see them at 2 weeks and they're still in pain and sore, that may also be a sign that you may have a graft failure on your hands.
Okay, we have a clarification on another one of the questions regarding the post-op visit for the 4-walled graft site, seeing particulates getting rinsed out. At 2 weeks post-op, the particles looked totally non-integrated and rinsed out up to 4 millimeters into the socket, and a few weeks later, soft tissue grew over it. Do you have, I guess, any advice to a situation like that?
Yeah, so if I'm hearing it right, at 2 weeks you're getting particles, out of the graft still not healing over. Couple things could have happened. One is you can have a socket, not literally a dry socket, but we all have teeth that we take out, and the socket literally is not bleeding at all. One thing to help with that is to do some cortical perforations, or at least utilize the RAP involvement, the regional acceleratory phenomenon, where you scale the walls and do some bleeding. That will typically help, because the way sockets heal is you have to have clot formation, and then a layer of granulation tissue forms over the graft, and then you're supposed to have epithelial migration over that graft. So if you're still getting particles out, it could mean that you overpacked it. That's one possibility. So whenever you graft whenever you place a socket graft, you want to be careful not to overfill it. And the definition of overfill, a lot of people will fill the socket all the way up to the level of the soft tissue. You don't want to do that. Where you want to stop is the level of the adjacent bone. So if you take your final post-op radiograph, which I always do after I place a socket graft, I always take a PA or a bite wing. The bone should be level with the adjacent interproximal bone. And if it's not, if you packed it all the way up to the soft tissue, then that part's going to fall out, and then you are going to see some graft particles at the 2-week post-op with the tissue not healing over it. So that might be the answer there, is that you may have overpacked the socket.
Okay, and what technique do you use at extraction day?
As far as the extraction technique or the bone graft, we'll try to address both of those. So extraction day, we make the decision on the technique after the extraction. So our extraction technique always involves the use of a 15 blade, always involves the use of a periotome, and then the extraction forceps of your choice. So we always try to keep the labial wall intact. So let's just start from there. So once the tooth is out, we do a socket graft analysis, and that is done with a simple periodontal probe. If we can feel a labial plate, and if that labial plate is 1 millimeter or half, let's just say the labial plate's intact, let's just start there. We'll just graft the socket with Mineros and place a figure-8 suture and be done. We're done. Okay. If during the course of using our probe along the labial wall we notice a 5 millimeter diameter fenestration or smaller, we do the ice cream cone technique. If we notice that there is no labial wall or no labial plate at all, then we'll decide to use a full thickness flap reflection and graft the socket in the manner using Mineros and the Memlock membrane, and achieving primary closure after that.
Okay, when using cortical mineralized particulate bone graft for socket grafting, when do you usually re-enter for implant placement?
For socket grafting? Was that the question, Corinne?
Yes,
sorry.
For socket grafting.
Okay, yeah, so we will implant placement will go in 8 to 12 weeks after the socket graft.
Okay, do you find infection at the site a problem during grafting, and is debridement enough to avoid graft failure?
Yep. So if a patient has an active infection, once again, we'll put patients on antibiotics, 1 to 2 days before the actual socket extraction and socket graft. But at the time, remember, remember the 4 S's of bone grafting. You have to have a clean surface. So when you take the tooth out, you have to degranulate that socket. So if you have, granulation tissue in there, or where your periapical lesion was, you have to remove all that to maximize your chances of a successful bone graft. But no, it does not adversely affect your final result as long as you remove all the local irritants at the time of bone grafting.
Okay, do you place your patients on steroids for either large grafts or implant placements?
I do. For large grafts or an anticipated large graft, we put them on we do put them on Decadron, 4 milligrams, starting 2 days before the graft. So a lot of people will just do a Medrol dose pack just because it's easier, but some people would advocate the use of a stronger Decadron dose in order to take a greater advantage of the anti-inflammatory effects of it.
Okay, how do you make sure all